Well, welcome everybody to Optometric Education Consultants webinar live. Tonight's topic is ocular biologics, biosimilars, and drugs for the eye. Our presenters are Dr. Greg Caldwell and Dr. Tracy Offerdahl. Dr. Greg Caldwell is a graduate of the Pennsylvania College of Optometry, where he did a one-year residency in primary care and ocular disease at the Eye Institute. He's a fellow of the American Academy of Optometry, a fellow of the Optometric Glaucoma Society, and he works in Duncansville and Johnstown, Pennsylvania as an ocular disease consultant, private practice. He's been involved in numerous FDA clinical evaluations. He has lectured extensively across the U.S. And in other countries. He was the past president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 to 2016. And he's president of the Blair Clearfield Association for the Blind. And it's also my pleasure to introduce Dr. Tracy Offerdahl, who attended Temple University School of Pharmacy in Philadelphia for her undergraduate and graduate degrees. She got her doctor of pharmacy degree and completed a residency at Temple University, where much of her time was spent in internal medicine and infectious diseases. She's currently on faculty at Salus University's Department of Optometry, where she's a course director and instructor for all systemic pharmacology courses for the students in optometry, as well as audiology and physician assistant program. And she is a clinical practicing pharmacist in patient care in Rosemont, PA. And she also, as Greg mentioned, is a fellow of the American Academy of Optometry. So with that, I'm going to turn it over to Greg and Tracy to educate us on ocular biologics, biosimilars, and drugs for the eye.
Thanks, Joe.
Thanks, Joe.
And I'll just jump in here real quick and do my disclosures. And the very first thing I want to point out is the content of this presentation was independently created by Tracy and I, Drs. Caldwell and Dr. Offerdahl. I've lectured, as you can see, from Alcon down to OptiView, and advisory board from Allergan to Dompe. And we'll definitely want to point that one out there, since we'll be talking about one of their biologics in here tonight. I sit as the PA medical director. I'm the chairman of the advisory council for the diabetic section for the healthcare registries. I don't have any financial or proprietary interest in any companies or products that are mentioned in this presentation. And more importantly, the content and the format of this course is presented without any commercial bias and does not claim any superiority over any product. And then Joe and I, the half owner of Optometric Education Consultants. Tracy.
Mine is very boring compared to Greg's. I have no financial interest in any of the products mentioned in this course, and I've received no assistance in preparation of this course.
And before we start, I want to let everybody know I just added two handouts to the chat. It's the same material in different form. One is a handout, the other are the slides.
Thanks, Joe. And Tracy, can you kind of maybe just go through this slide, just, kind of the start off of biologics and just, how they're different from just maybe traditional pharmacological medicines that are out there?
Sure. Everybody's seen some of the biologic commercials that are out there now. The market is flooded with biologics from not just the ocular realm, but also, other systemic diseases or conditions, or additional systemic diseases and conditions. So the main thing is kind of differentiating a biologic from what we call our traditional or small molecule chemicals or small molecule drugs, whatever you want to refer to them as, and you'll see them referred to in many different ways. So you might be surprised to know that we've had biologics for a long time. It includes our vaccines, some of our blood products, some of our stem cell injections, our COVID vaccines that we have now are considered biologics. And, we've all heard of how Pfizer has to be 94 degrees Fahrenheit, and they're very susceptible to percussion and temperature fluctuations as well. That's true of most biologics. They have very tight parameters in terms of how they can be stored and how they can be moved, et cetera. But when you think about, your small molecule drugs or small molecule chemicals, or non-biologics, if you will, I mean, think about it. You might have a bottle of ibuprofen or acetaminophen, or maybe some of your prescription drugs that you keep in your pocketbook or you throw in the glove compartment of your car. That would never be okay for a biologic, and we'll go through some of the reasons why. For today, we're really talking about kind of the second generation biologics. Some of those you recognize I have listed here: the Humera, the Remicade, the Enbrel, and some that you maybe haven't even heard of yet. The interesting thing about the biologics is they're very complicated to manufacture. So the actual identification of the chemical itself isn't the hardest part. It's actually manufacturing it into a usable and stable product, which is the most complicated of the endeavor. So most of the biologics, all of the biologics that we have, are made from living organisms. Or initially came from living organisms. I'm going to get the remote control from here, Greg. So, when you look at some of the ways that biologics exist and are made, it's going to be kind of an interesting buildup to what we're going to go through. We have a poll question in progress.
Yep. So, I think though, you kind of touched on this a little bit, but one of the biggest differences that, that I learned when putting the lecture together, or when learning about biologics, are they large molecules, small molecules? We're talking about all this nanotechnology, or the super small molecules, or you just don't know. And that's a good answer, because that's the reason why we're here tonight. So biological drugs are large, small, nano, or I don't know. And people are weighing in nicely here. And I think we got a pretty good sample here. So I'm just going to end. And we're going to see, Tracy, glad we're holding this this webinar tonight, because it is showing that we got large molecules winning or tied with small molecules, both at 26%. We have nanotechnology in there at 23%. And I don't know at 25. So you couldn't almost get any more perfect than that. 25, yeah. 25, and 25. So welcome, everyone. And that's why we're here tonight. So let's jump into this small versus biologic drugs. And Trace, why don't you just grab the control there? And if you want to just maybe go through these, and where you want me to interject, I will.
Okay, so it was a great question, and I didn't touch on it too much yet. But our traditional medications that you think of, our antibiotics, are even the chemicals that make up a lot of our ocular meds, our aspirin, our ibuprofen, our acetaminophen, etc. They're all considered to be small molecule chemicals or small molecule drugs, and they're pretty simple to make once you know the structure of the drug itself. And as you can see here on this slide, it says you're literally just adding this chemical structure and mixing it together with non-active ingredients and different reagents. It's very controllable, it's very predictable, and it's literally just a basic biochemical reaction or medicinal chemistry or organic chemistry. Of course, it was difficult, to discover it, but once it's known, that's why you have so many different generics that are available for a lot of brand name products once they expire. It is a known chemical that is easily mixed with other things to produce a generic. So as soon as a patent expires, there are some products that have 10 or 11 or 12 generic manufacturers that come to the market. Biologics, on the other hand, are made by harvesting harvesting substances that are produced and secreted by cells. So it's genetic engineering, pretty sophisticated and sexy biochemistry here. So looking again at the size and complexity of biologic drugs, we'll just run through some information real quick. Small molecule drugs can be taken orally generally, and they tend to work within the body in the cells. Biologics are very large compared to our small molecule chemicals or drugs. They're typically injected. Some can be instilled as an eye drop, which you'll see here tonight with Sjogren. And a few of them now, particularly some of our anti-rheumatologic biologics, are available in oral form, but that's a really new technology as well. So if you look at the first or the third eyeglass bullet here, it says small molecule drugs such as aspirin, composed of only 20 to 100 atoms. So that doesn't mean a lot when you don't have something to compare that to. But look at our small biologics such as hormones, and that could be insulin. That's one of our examples here, composed of 200 to 3,000 atoms. So it's just showing you we are getting into some bigger sizes. But look at our large biologics, antibodies, human growth hormone, again, our Sjogren, our Teplizumab. We are now seeing 5,000 to 50,000 atoms. Huge, huge products and sizes. This picture I always have in my mind. I was working today in the pharmacy and in the clinic, and I was trying to explain to a patient about growth hormone. So I'll show you exactly what I mean by that here in a moment. But you see aspirin up here at the left, it's 180 Daltons. It's just a unit of measure of weight. Insulin is 51 amino acids and about 5,800 Daltons. So this is an insulin structure here. Somatropin, which is growth hormone. This is about 22,000 Daltons. And then down here we have immunoglobulin G, which is, a biologic structure. So I was trying to explain to this patient when she mixed her somatropin, this one up here on the right, why it was important not for her to mix it. She said, well, normally when I mix all my medications, I inject the water into it or the diluent into the powder, and then I shake it. And I, was thinking, oh my gosh, that's a terrible idea for most injectables. You don't need to, you inject the diluent into the powder. If you just watch it for 3 seconds, it already is clear. And I said, picture, a couple balls of yarn, and you take those balls of yarn, you kind of smush them together, and then you throw them on the ground. That's what these structures look like. So if you make a lot of noise or you cause a lot of movement, these structures will break up. It's literally like balls of yarn that have been randomly thrown on the ground. So they're very susceptible to temperature and percussive movements for sure. And again, I love pictures. Greg and I found some great ones for this discussion. Size and complexity of biologic drugs. Again, we have our small molecule first. Here's our aspirin. It's complexity like a bike weighing about 20 pounds. Our large molecule, this is human growth hormone, about 3,000 atoms, and the car about 3,000 pounds. So that's probably like a Mini Cooper, it looks like there. So a 20-pound bike versus a 3,000-pound small car. And then our large biologic, immunoglobulin G antibody, about 25,000 atoms. And it's essentially the comparative complexity is like a business jet. So it's crazy to think that, the diversity from an aspirin chemical to the complexity and size of the large biologics. It's pretty amazing and sophisticated medicine for sure.
So I'm going to grab the remote here, Trace, to do this polling question. So here's one of the biggest things that I've learned whenever doing a biologic is, biologic drugs are produced by inserting DNA into what? Is it bacteria? Is it yeast? Is it viruses? Is it all the above, or you just don't know? And again, don't know is a good answer because that's why we're here, and that's why we do the webinars to help out our colleagues. So is it get inserted into yeast, bacteria, viruses? So it goes into it goes into a living organism. Which one is it? And look at that. We got plenty of people rolling in already. Give it a second or two. And I'm going to end the poll. I'm going to share the results. And we have 3% yeast, bacteria at 10, viruses at 21. Leading the way is all the above. And I don't know is 25%. So let me get ready for the next polling question here. And Trace, why don't you talk about that a little bit?
All right. So essentially, it was, all of the above. Not only is it yeast or bacterial or viral or mammalian cells, we literally have a piece of DNA that's inserted into one of these living cells. So we've given you kind of the abridged version of how a biologic is made. So first, you've got that insertion of DNA into one of these living cells. These cells then produce a large amount of a specific molecule, and usually it's a protein. The desired molecular isolation then takes place, and then all of the living material and cells are removed, and then only the desired chemical molecules are left. So most of the living components have now been removed from the structure itself. But the interesting thing is the origin of these biologics is still from a natural substance. That's going to be key. The isolated molecules then become the active ingredient of the biologic drug. So of course it's a lot more sophisticated than this. We make it look so simple. The chemists and researchers that produce these would probably, smack their forehead thinking, geez, you make it look so easy. But the truth of the matter is it's a nice little algorithm to kind of show you they come from living cells. We're working with DNA here. It's a very sophisticated genetic engineering type product. But then in the end, it's pretty easily pulled apart, and made into this biologic chemical. The hardest part of this entire process then is how we take this biologic and make it into a usable substance from a therapeutic perspective. So the next slide says the making of biologics. We'll just look at a couple more points so you have a good perspective on some of the information that we're going to run through. So again, the molecules in the biologics are going to be different from those in most other pharmaceutical products because of the large size, which we already saw, the lack of uniformity. Think of that ball of yarn or couple balls of yarn that we just looked at, and weak chemical bonds. That's the one we haven't mentioned yet. And truly, when you think of just picturing that human growth hormone, the somatropin, and the immunoglobulin G, IgG, and there were size differences, but they literally looked like that yarn kind of weakly floating around, against each other. That's that weak chemical bond, which is the major thing that makes it so easily broken down with percussion and temperature changes. So our weak chemical bonds, I already said they're relatively weak and they will degrade if we don't follow the guidelines and storage, et cetera, exactly. Because the molecules that make up the biologics are so sensitive, not only must the manufacturers follow specific steps, on how to make them and store them, et cetera, even teeny differences in manufacturing and packaging process, as well as our storage and administration, can affect the drug's ability to work. So again, just making a point of reference that we've all heard 1,000 times in the past 8 months or so since the vaccines have come out. Think of all the press and all the news reports, et cetera, that you've seen on, oh my gosh, how are we going to get these vaccines to where they need to go, considering the storage issues and the short amount of time that once you actually bring the vaccine to room temperature and then you actually mix it, how long it's stable. This is a perfect example of what we're talking about here. Now, you may have also heard this term biosimilar. This has popped up more in the last, 3-6 months than in the last 2, 3, 4 years. And there's a very specific reason for that. The word biosimilar is really the closest thing that we're ever going to get to a generic. And if you were not looking at me when I said that, I used air quotes around the word generic, and we'll show you why here. The biologic, like we said, is sourced from natural substances, human, animal, or microorganism. We said it's very high tech, it's biotechnology, it's genetic engineering. The difference between the two, the regular or chemical drugs and biologics, we can kind of make that quick comparison just to remind you while we go into the description of biosimilars. So very quickly, remember our regular chemical or small molecule drugs are synthesized with a known chemical structure, very easily made into another oral product, topical product, etc. Our biologics are huge, they're complex, they're not easy to identify, despite the fact that the actual structure of the biologic substance is considered public domain, so to speak. In other words, that's why I mentioned that's not the hard part. So the actual biologic structure is kind of in the public domain so that other people can see it, because that's not the huge part. The huge part is actually then making it into a usable substance or form that can be used from a therapeutic perspective. With a biosimilar, that is very difficult because these biosimilar companies that are trying to come out with a sort of generic of the biologic substance or the innovator product or the reference product, as we call the biologic, it's not so easy. You'll see here in a moment that we have some other ways to describe it. The main thing about a biologic, why we spend a lot of time seeing it in the press now, and why we spend a lot of time talking about it in pharmacology and in optometry now, is because typically biologics come out because they are being used for medical conditions or diseases or situations where there's no other treatment available, or the treatments that are available are completely substandard compared to what you could get from a biologic. I mean, think of even something like, I'll go back to Remicade or Enbrel or Humera, or some of the ones you see commercials for with the psoriatic arthritis and psoriasis and things like that. When you think back on what we've had available, even just for psoriasis, and I don't mean to diminish psoriasis, but just saying something like that, that isn't always a full systemic painful disease on the inside, but certainly is psychologically painful. It's, very hard disease to live with. What did we have before the biologics that cost thousands of dollars a dose? We had creams, and we had, lights and, phototherapy and things like that. We didn't have anything that was good. Come along with a biologic, and now we have these drugs that are able to completely change the course of the patient's life, not only cosmetically, but physically, emotionally, systemically. Amazing stuff. So they cost thousands of dollars a dose typically. How do we get the cost down? That's where biosimilars come in. A biosimilar, the name is very descriptive. A biosimilar means highly similar. Just means it's pretty darn close to the reference product, innovator product, or the biologic or reference product. And we'll show you some examples of that because it's a little hard to wrap your head around until you kind of see, oh, that's the biologic, that's the biologic, otherwise known as the innovator product, otherwise known as the reference product, and this is the biosimilar. We'll show you some examples of that to kind of clear up any confusion. The job of the biosimilar company that's coming out with this kind of like a generic, their whole purpose, their whole job is to prove biosimilarity between their product and the reference product. They are not going to independently establish safety and efficacy. That's already been done by the biologic company. So once a biosimilar is approved by the Food and Drug Administration, then you can say the following, which is in the middle of the slide here. There are no clinically meaningful differences between the biologic, otherwise known as the reference product or the innovator product, and the biosimilar in terms of safety, purity, or potency. And it takes a long time to get there for these biosimilar companies. So there's no difference in safety, purity, or potency. That's important. Again, why is there no such thing as a generic biologic medication? Because biologics come from living things, living substances. So it's pretty much almost impossible, not completely impossible, but pretty close, that there's going to be an exact copy of the reference or innovator or biologic product, because we not only have, slight differences and even just different different lots of a biologic product, but what about all the inactive ingredients, et cetera? It's never going to be an exact copy. Whereas generic medications, they may also have different inactive ingredients, but they are synthesized with that exact active ingredient, which is identical to the brand name medication. So it sounds like we're splitting hairs, and we are kind of splitting hairs, but it's important to understand why you're going to see so many biologics coming out, and then the biosimilars that go with them. So this is just a good graphic. I'm a visual learner, so I like to make sure, and Greg and I always put in a lot of graphics. Just look really quickly over here on the left-hand side of this graphic that is just showing you the difference between a biologic and a biosimilar in terms of manufacturing. So the originator biologic, the brand name product, if you will, look at the molecule characterization here at the bottom. That's a very small part of this upside down triangle. Then they go through non-clinical studies, phase 1, phase 2, phase 3. You know, it's in this phase 2 and 3 that they spend the majority of their time. And it takes a heck of a long time for a biologic, for the structure to be found, for all the or the in vitro studies, and then the in vivo in animals and humans, et cetera. It takes a long time. Once the product is out and the biosimilar company comes along, they spend a good amount of time compared to the biologic company. The biosimilar company spends a decent amount of time looking at the physicochemical characterization of the product, the functional or biologic characterization, and then they zip through the in vitro and in vivo studies, because once they have the right formula put together, it's kind of like once you know all the components of ketchup, then you can take that ketchup and say, oh, it goes on a burger, it goes on a hot dog, it goes on eggs, or whatever people do. Once you actually have the recipe, the formula, then the rest is easy. You know, you're just making dollar store ketchup compared to the brand or whatever. You've kind of figured out, you know, what's in the sauce, so to speak. So your job is a little bit easier. This graphic I like. It usually is moving, but essentially what I wanted you to see is the FDA has a big push for biosimilars. And it just said, you know, to give medication to more people. And this is one of their advertisements. I thought it was very clever. So that's biosimilars that they're advertising. And it wasn't always like this. The FDA and biologic manufacturers were very against biosimilars for many years because they thought, one, it's impossible to make a generic to a biologic. So that's where we get the biosimilar name. We're just going to make it really similar. And of course, the biologic manufacturers were like, oh, no, 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 no. You can't make something that's like us. It's impossible. It's impossible to do that. Why make such a stink over biologics in terms of, you know, really pushing to get them? Well, it's cost, and to make them more available to more people, from a $15,000 per 6 weeks dose of Remicade down to down to maybe rather $2,000 every 6 weeks for a biosimilar. So Remicade is, you know, the brand name product, and the biosimilar is just unable to call itself Remicade. It's going to call itself the actual biologic or structural name, and we'll show you those. Infliximab is Remicade brand. Infliximab AXLU is the biosimilar. So we'll go through quite a few of these. All right, and the last couple things here, and we'll get real quick into the medications. The monitoring parameters for biologics are really interesting, and we're going to kind of lead you through how it changes with the ocular biologics. So the first thing to just remember very quickly is, since biologics come from living things, as much as I love holistic medicine, it's my first love. That's, you know, I'll always say, hey, I'll take that herb instead of a drug. You know, of course, all the legal herbs, I always say, because, you know, it's the closest thing to nature, and it's like eating lettuce in a pill form sometimes. But here's the interesting thing. The human body looks at anything that comes from a naturally occurring substance, plant, animal, or human, and is like, I really don't like you. So it might look at acetaminophen and think, I really don't like you either, but you're less of a problem than that aspirin or that sulfa drug or that codeine sometimes, or, you know, the penicillin. Thinking of the 4 top things, substances that you see listed as an allergy. So let me do that again in case you drifted out there for a second. This is an important point. Aspirin, penicillins, sulfa agents, and sometimes codeine. Why are they some of our top 4 allergies pretty much everywhere? Because they come from naturally occurring sources. They are not synthetic at all, or maybe just a little bit. Our body looks at anything that comes from nature when it's given consistently. It's one thing if you take it a couple of times, your body's like, okay, I don't really like you, but if it disappears, then we're good. We're back in homeostasis. But if you're taking a biologic that is going to be used every 6 weeks in perpetuity, your body's going to look at that and think, I'm going to produce a mini graft versus host disease. I'm going to produce an immune response to try to get rid of you. So the chances of, pretty severe adverse effects can be remarkable, but we're going to see kind of a process change over the course of some of these agents, because you're going to see with Tepezza, it's not as bad because of how it's working. With the Senagermin, it's not as bad because it's an ocular med. So let's see how the genesis of this changes as we move through the rest of these agents. So real quick, this is what we're going to look for. Biologics are all immunomodulating and immunosuppressive medications. They have high immunogenic potential because they tinker with the immune system. The immune system does not like to be tinkered with, ever. Sometimes we have to do that in terms of vaccines, but it doesn't like to be tinkered with. 2 things typically happen when we tinker with the immune system: potential for allergic reaction and potential for that, kind of zero cell, which is a carcinogenic effect. And we're going to see that pop up today in some of our older biologics, older compared to the few that have come out in the past 2 years. The other thing is, because these are immunomodulating and immunosuppressive, with many of these, you have to get tested for tuberculosis. So you get that little skin test, wait to see if it reacts. Many of them are having patients test for tuberculosis, hepatitis, etc. And we'll look at the questions here, and let me see if there are any for me. But once a biologic is initiated, if a patient is sick, has any cough, flu, illness-like symptoms, the biologics traditionally are not given until the patient is well. So it's a lot. People look at these and think, did you listen to all the real fast talk on that commercial? Why would anybody want to take that? Well, because they don't really have another good choice. So you take it because it's going to make your life better in terms of morbidity and mortality from your disease. And then we just watch for the side effects. Okay, let's see here. What do we got? Next slide. All right, our ocular biologics. I'm going to turn it over to Greg for a little bit.
Let me just launch this poll, and it's a launch. All right. With that being said, which biologic drug has been used in eye care for the longest? Has it been Oxavate, Tepezza, Actemra, Avastin, and I don't know. So as this is being answered, if we jump down here, everyone who's answered, if you look at C and D, and if you look how it ends in MAB, you'll see that that stands for monoclonal antibody. Oh, let's see if I can go back here. There we go. It stands for monoclonal antibody. So you can tell that that one, and same thing with Tepezza, you can tell that that's a monoclonal antibody. So I'm going to go up here. I'm going to end the poll. Everyone has pretty much nailed it. That's out there. I'll share the results. And the results are, yes, Avastin is the longest used in eye care here. And this is where it all started in the eye. Disorders for blood vessel diseases in the retina are responsible for some of the most common causes of blindness in the world, meaning retinopathy of prematurity, diabetic retinopathy, and then age-related macular degeneration. And so it all started with the vasoendothelial growth factor, the VEGFs or the anti-VEGFs that are out there to inhibit. So one of the things that I like to talk about is we talk about steroids, and they kind of suppress the whole immune system, where biologics find that whole complex will just target and kind of be, a missile And that's what happened here was they found out that vasoendothelial growth factor created those blood vessels. So they found something that would just target that rather than, in a sense, maybe suppressing that whole blood vessel. So that's where it all started, was with choroidal neovascular membranes. And, you know, we have things back in the day like Macugen, and you can see here Avastin and Lucentis moving into Eylea, and Beovu was the most recent one that has come out within the biologic market for the anti-VEGF. And you can see, you know, the different RNA and DNA ways that they are infused proteins or humanized full-length monoclonal. There's your monoclonal antibody. And those are big, complex molecules that need to be met. So with that being said, we'll do polling question number 4 here. And polling question number 4 is, which biologic drug is for the treatment of neurotrophic keratitis? And we'll see how well the marketing has been paying off over the last few years. Neurotrophic keratitis, which biologic? Is it Oxavate, Tepezza, Teprotumumab? Is it Actemra? Is it Avastin? Or I don't know. And so, Joe, any questions roll in there since we've been doing this? And I see you've launched the handout a couple times, so thank you.
Yes, no, there have been no questions. I've been watching.
Perfect, thanks. I'm going to end the poll. I'm going to share the results, and you can see here 44%. We got it. Oxavate is used for neurotrophic keratitis, and we'll jump into that. I'm going to stop sharing and get ready for poll number 5, I guess, and jump in here. So Oxavate, Center German. Now we have that BKBJ. We'll explain that here in a second. Was approved in August of 2018 there. Hold on, Trace, don't grab it. So we have Dompe Pharmaceuticals, and it looks like I might have spelled pharmacy wrong. And that's because this is an Italian company here. And the ophthalmic solution indicated for the treatment of neurotrophic keratitis. It's 1 drop 6 times a day, basically every 2 hours for 8 weeks. Now, the key here is Tracy kept talking about how fragile this medication is. And when this comes over from Italy, they were explaining to me, I was talking to the medical science liaison, they can really only stack them too deep. That's why it's in a glass bottle. It can't be plastic. And this is really the first biologic, at least for the eye, that's not infused or it's injection. It's used as an eye drop. These are so big molecules, but you're going to see here that this isn't a monoclonal antibody. This is basically endogenous growth factor here, neuro growth factor. The contraindications are none. So one more here, polling question that I think will drive home some of the points that I wanted to make here is, which living organism is used to produce Oxavate? So, and we're going to explain that here in a second. So are they using E. coli? Are they using a Chinese hamster ovary? Are they using COVID-19? Are they using Staph aureus, or you just don't know? So in a sense, this endogenous neuro growth factor, they figured out the sequence of it. They're injecting it into one of these live organisms. They're using the live organism to produce a very long chain, and then their proprietary way, as Tracy talks about, spinning it into that ball of yarn, and then being able then to ship it and then make it into an eye drop. So let's see here. We're getting pretty good. And going to end the poll, going to share the results. And we have here about 19% saying E. coli. Chinese hamster ovary is used from time to time, obviously not COVID-19. Staph aureus, and the majority just don't know. So let's stop sharing that. And I'm going to, I think I have a nice picture showing up here. They use E. coli. So that's what they're using to make Oxavate is E. coli. Again, they found out the sequence, the molecular structure of endogenous growth factor. And they're able to put it into E. coli. It spits it out into a really long chain. And again, the proprietary mechanism of spinning it back up and making it look like endogenous growth factor and then turning it into an eye drop. So where does Oxavate come into play? Well, right here where it says corneal nerves. And what happens is we want to return, or the issue, what happens with neurotrophic keratitis is that you break down this cornea homeostasis. You're breaking down this loop that occurs. You have neurotransmitters that provide trophic support, stimulate wound healing, maintain anatomical integrity, and that's the epithelial cell and the karyocytes. And then you have, again, nerve growth factor from the epithelial cells and karyocytes that are part of survival and differentiation and maturation. And then tears contain growth factors and nutrients. But the corneal nerves, if they're just not working, which happens, which is the easiest way, and I'm going to show you that I really didn't do much corneal nerve testing other than for herpes simplex over the years until this medication comes out. And one of my clinical pearls is going to be is maybe start figuring out what normal corneal sensitivity is so you can see these patients. And a really good way would be, how many times have you had someone come in maybe with dry eye and you put some staining in, or someone that came in with a tiny, tiny cornea abrasion and it's just staining so slightly, but yet, it's staining so slightly, but they're in a ton of pain. But then you have a patient that comes in that you use sodium fluorescein and it looks like a Montana night, where it's just lighting up and the patient's like, yeah, I think my eyes feel fine. That's probably a patient that's neurotrophic. And if you would take out your cotton wisp from your cotton tip applicator, and I'm going to show you that shortly, and touch that eye without any anesthetic, you would find that that cornea is not innervated well and it's neurotrophic. So the pathophysiology of NK is, loss of corneal sensitivity, loss of corneal nerves, impairment of corneal sensitivity, and then it leads to impairment of the trigeminal nerve. And this impairment is what leads to neurotrophic keratitis. So at the top here, you'll see impaired corneal trigeminal nerve. And then you get the impairment of the trophic supply, you get impairment of the trigeminal reflex. Then that leads to epithelial alterations and then spontaneous breakdown, leading to then this cornea that stains. And then when it's staining, but the patient's like, no, doc, like you're leaning around the slit lamp going, are you for sure? Because I just saw one a few minutes ago that had very little staining on their eye. And man, they were in a ton of pain. So that's kind of maybe like, I'll say, the poor man's way of diagnosing neurotrophic keratitis. But then you can use a cotton tip applicator. Now, etiology is associated with neurotrophic keratitis. I think we're all familiar with the herpes simplex and zoster, since they kind of hibernate until they come out in that trigeminal nerve. But you can see there's a whole laundry list. People that are maybe using chemicals every day, like glaucoma patients, that glaucoma medication and maybe the benzalkonium chloride can create a neurotrophic keratitis, or chronic ocular surface or inflammation from dry eye, or cataract surgery, or LASIK. And that's kind of more the ocular, but then the central nervous system, the neoplasm, the aneurysms, systemic diabetes, right? Isn't neuropathy, right? Fingers, toes, our eye, we're so focused on what? Diabetic retinopathy, but the cornea can lose its sensitivity, and the cornea can end up with a very bad SPK from diabetes. And there's your neurotrophic keratitis that's out there. So there's different stages, mild, moderate, and severe, depending on, you have more of a like more of an SPK, and then it becomes more persistent. The cornea is becoming more anesthetized, self-anesthetized, and then you start getting stromal involvement in stage 3. And that's where you don't want to be. We want to kind of diagnose these in stage 1, and we can intervene. So the assessment of corneal sensitivity is the essential way of diagnosing neurotrophic keratitis. And they call this a rare disease, where they're saying, I think a rare disease is less than 2,000 a year. But I think it was less than 2,000 a year because, one, we really didn't test for it. And we really didn't test for it is because we didn't have a treatment. So now we have a treatment, and I can tell you, my end of using Oxavate in my practice is probably close to 10 or 15, and this is supposed to be a rare disease. Now, let me just show you a quick video here of a cornea sensitivity testing. This is me. Let me just kind of show you, and I'll kind of set this up. All I did is I took a cotton tip applicator. I just kind of take my fingernails, pull off the top, and then there's a little wisp. Sometimes I'll twist it. And then you're going to see me barely touch the right eye of this patient, and they just blink away. There's no anesthetic in the other eye. You're going to see some sodium fluorescein, but it wasn't fluoresce. But you're going to see how I can drag that right across that cornea. So cornea sensitivity is very important. Watch what happens here. I have it all set up. Just a fiber, and watch, touch, boom, patient blinks, touch, boom. Great cornea sensitivity. You can check all 4 quadrants and central. So you can check 5 areas on that cornea. Now here's the other eye. No anesthetic. That's a neurotrophic cornea right there. I'm dragging that across. You see the patient's not blinking. They had no idea that I was doing that. Again, not anesthetic on that eye. Now, that eye right there is not neurotrophic from dry eye. That is a simplex ulcer getting ready to erupt, and that's how I made the diagnosis. But you can see that's how you can check, and I do that for my dry eye patients quite frequently. Now, what is Oxavate? Oxavate is a replica of endogenous growth factor. That's why it doesn't end in that monoclonal antibody. They actually figured out the sequence of endogenous neurogrowth factor and literally put it into that E. coli. It spits it out and it twists it up into, I guess, what we could call exogenous neurogrowth factor. And then we get it turned into an eye drop. And when you have endogenous growth factor, it helps with the corneal innervation, the cell proliferation and differentiation, and tear secretion. If you break down the electrical part and the components that are getting it, that's why it's so hard to sometimes fix these corneas that are not sensitive. They just get no feedback. That feedback loop is broken, and we have to bring the feeling back to the eye in order to get it to work properly. So active ingredients are structurally identical to human growth factor. And this is what Tracy was talking about when she went through what a biologic is. And you can see how large and complex this neurogrowth factor, this endogenous neurogrowth factor is. And that's really the proprietary part of this, printing it out using, E. coli, trying to twist it up and make it look exactly like endogenous growth factor. And they've been able to do that. And that's what Oxavate is, or Centergermin BKBJ, the ophthalmic solution, which is 0.002%. And you get these kits, and it's delivered in 7 vial adapters, 42 pipettes. You get 42 sterile disinfectants, and a dosing card, because what they're doing is instilling this every 2 hours, 6 times a day for 8 weeks. And I just love this slide here, because here is what we could call the exogenous, and here's the endogenous, and what they've been able to come up. It sounds really simple. Well, if the cornea needs neurogrowth factor, well, geez, it's a simple solution, right? Just make it. Well, a little harder, right? That's where the scientists, where Tracy said, ha, 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 you have to put it into E. coli, spit it out, twist it up. And I really like the animation on this because it is exactly the same copy that we're able to do with biologics. That's what a biologic is. And when you use Oxavate every 2 hours, 6 times a day for 8 weeks, you get some really good feedback. Tracy, I know I went through a bunch of slides there, and I'm sure you got lots of things swimming through your head there. Do you want to talk about a few things before I play a couple of these videos?
No, keep doing the videos and we'll hit it at the end.
Okay, so here's a patient of mine, one of the earliest patients. I knew she would be great at this because we've been trying to battle this neurotrophic keratitis for years. And what I found out, and I want to play a couple of these videos, is when you listen to her, she's going to say like the foreign body sensation is gone, but her eye is more sensitive. Her eye is more sensitive. The foreign body sensation is gone, but she feels better, right? She's getting a return of the way her eye should feel, and we're getting rid of that foreign body sensation as it goes by. So let's see if this will work here, if the sound will play. All right, here we are, 1 week into Trace, able to hear that?
Yes.
And we have a patient
Thanks, Joe.
that's going to give us her experiences of what's going on. So why don't you just jump into your list there and tell us what you got.
Okay, I've noticed that my eyes have become much more sensitive to the light. I barely need any tears at all. I've used them once a day, and one day I did not use any at all. My eyeballs themselves feel sore when you move your eyes or open and close your eyelids. But I no longer have the sensation that there's something in my eye. They are very soothing, and they feel better.
And you're using what type of tears?
I'm using Refresh Optic. Usually I finish the eye drops, the last one for the day is at 6:30 in the evening, and usually by 9 or 10
All right, here we
o'clock.
are with our weekly follow-up with our patient. We have
This is now
time 0
week
up here,
3.
and then we have a week after Oxavate, and then 2 weeks, and you can see we had a nice improvement today.
Look at that return of corneal
with the SPK
epithelium.
with Oxavate. So let's swing over here to our patient, and how's there any difference between last week and this week, or since we started?
The biggest difference is I can now read. Any time of the day I would choose. I can see clearly, and it's a big improvement. And my eyes feel good.
The eyes feel good.
Yes.
So other than that, you said there's really been just status quo since last week.
Yes,
is that correct?
the still a little bit of discomfort, nothing bad.
Good.
And I'm very happy with it.
Good.
So I'll play this last one.
Okay, here we are, week 6 tomorrow. We'll finish up week 6. There's our beginning, all the SPK, just a little bit of SPK up top. Obviously the right eye was the worst side. You can see the SPK starting 6 weeks ago, and just a hint of this keratitis up here towards the top. Week 6 here with Joy, and tell us what you got. You were telling us about how it's nice to wake up in the morning.
I get up, my eyes do not hurt when I get awake. I don't need any refresh immediately. In fact, I think in the past week I've only used refresh 2 times at bedtime. My husband has enjoyed the eye drops coming in dry ice. He has used it to make ice cream.
That's a maybe an off-label use of the dry ice, but
Dry ice.
but definitely a benefit.
Yes.
We're not I guess responsible for any weight gain for him. So tell me about the vision. Have you noticed anything with your vision?
My vision is much better. I can read without difficulty, play the piano. When I'm driving, I can see the signs without having to be really close to them. It's just made a real world of difference.
So with that being said, I think you guys got the idea here. What I'd like to point out with the N of 10 or 15 that I've had, again, they all come in talking about how they can feel their eye more, but it doesn't hurt. They're getting that sensation back, but yet the painful sensation is leaving, like that foreign body sensation. So it's kind of a neat medication as the eye begins to feel again. And so, the study came out and it showed after 8 weeks of treatment, 6 times a day, 50 clinical trial sites that, and there was a European study and a United States study that after the 1 8-week course, 80% of the eyes remained healed after 1 year. And so, Oxavate is the adverse reactions. It's very well tolerated. The most common adverse reaction in clinical trial was, again, this eye pain, cornea deposits, foreign body sensation in the eye, some hyperemia, swelling of the eye. And then if you're going to use contact lenses, make sure that you remove them before applying it. And you're just not going to do that because they're putting it in every 8 hours. And really, the key with this medication, I want to highlight why we started off by talking about how delicate this medication is. If they're using other medications, if they're using things like Xiidra or cyclosporin or Lotemax, even Vital Tears, I do some Vital Tears. This medication is delicate. So I like using nothing with the patients. We try, unless there's an infectious, maybe risk of infectious keratitis where we'd use an antibiotic. But, contact lenses, they should be removed for applying, but they're going to be putting it in every 2 hours. So they're going to go in and out. And really, it's going to damage that molecule. So I just tell them no contact lenses for the next 2 months, unless they have like a wedding or something that they're going to go to. So, okay, Trace, before we jump into thyroid, I'm sure there's some things that you want to talk about with this medication. So jump in.
Actually, before you do, a question did come in, and I'm not sure if you're going to talk about it, but you may not. How does she pay for this medicine? How does she afford it?
Well, so the key with this is the nice thing is that it is a rare disease. And one thing that Dompe has, so if you look up how much this drug costs, it's $90,000, right? But the good news is that it falls into a rare disease category. And what Dompe did is they formed a foundation, actually 2 foundations. So we've got down a system at our office. Thank goodness for Sarah and the other teammates. She will initiate, we get the patient to sign, they tries going through the insurance company. We actually had a couple of insurance companies cover it. But then if that doesn't happen, it triggers this whole line of events which Dompe has that triggers off these foundations. So I've actually are 15 for 15 for patients that need it. Yeah, it sounds expensive. But there is a process, and Dompe has really put a lot of thought behind it to get it for this patient. But what's for these patients that need it? But what's helping it is the rare disease category.
And Greg, one more other question that popped up as well. It says, given her keratopathy, could this patient have benefited from concurrent autologous serum tears, given the epithelial growth factors and nerve growth factors too?
Absolutely. Yeah. This patient right now is currently being maintained by the only one I know right now is Vital Tears, and she gets Vital Tears. She's using 20%. They're called ACED, autologous serum eye drops, 20%, 6 times a day. And that's what we've maintained her. I tried before using that on Joy, as you heard her name, but just couldn't get her to where I needed. She had too much corneal desensitization, and she was desensitized too much. So we had to bring that cornea back, and now we're supporting it with her ACED drops. Yep, absolutely. But couldn't get her there alone. She had too much neurotrophic keratitis.
So looking at the side effects, just kind of think back before I handed it over to Greg, we were just mentioning very quickly the typical side effects that you're going to see from a biologic. So two things I want to say here. First, regarding the side effects, this is an ocular med. So the beautiful thing about this medication is you get very little, if any, systemic absorption. So the side effects are going to be a lot less scary than if this drug was administered systemically. So really very well tolerated. And as Greg mentioned, no contraindications to speak of. Most common events in clinical trials you would imagine are exactly what would happen when you put an eye drop in your eye pain, corneal deposits, foreign body sensation, etc. But really nothing spectacularly alarming. And then always the comment on contact lenses, therapeutic or corrective, they should be removed before applying Senegurmin to the eye or eyes. And mainly because if there is a lens in there, it may limit the distribution of Senegurmin, BJ onto the corneal lesion, and then they can be reinserted. Kind of the typical after most ocular meds, you can reinsert the lenses 15 minutes after administration. The second thing I thought to mention as Greg was getting into the discussion regarding Senegurmin, and he made the point to say, notice it doesn't have MAB at the end of the name. So you can see it's Senegurmin, and again, because it's essentially a copy of endogenous nerve growth factor. But what I wanted to point out is the 4-letter sequence at the end of Senegurmin. So this biologic, this is the innovator product, the reference product, it's called Oxavate, that's the brand name. It says Senegurmin BKBJ. These 4 letters are just part of the nomenclature for biologics and biosimilars. So when down the line, when and if there is a biosimilar available for Oxavate, so let's fast forward 3, 4, 5 years, and or maybe longer, maybe less, and let's say a biosimilar comes out for Oxavate, it will be called Senegurmin, and maybe it'll just have 4 different letters at the end. It will not say Oxavate. It'll simply say Senegurmin XLMQ, something like that. And that's how we can differentiate the two. It seems like such a little thing. I remember when some of these first came out, I was like, Senegurmin Bidge? What the heck does that mean? So I actually called one of the companies and they said it's random. Literally the 4 letters are random at the end. It's just to differentiate the two.
And the reason why they do that is because now there are registries being used out there. There's MIPS registries, there's outcome-based registries. So what they'll do is they'll plug in different treatments for those that are using a registry to see maybe in the long run when they're looking at the outcomes, does one perform better than the other? But you would have to be able to know which one was, and those 4 letters become very, very important.
Absolutely.
All right. Any other comments, Trace?
Nope. Good to
All
go.
right. I'm going to do a flyover of thyroid eye disease. And the reason being is because we do have a medication that's out there that could be used for thyroid eye disease. But I think you have to understand where this is in order to be able to understand. You have to understand thyroid eye disease that 1, it's an inflammatory disease, and 2, it's an orbital disease. And this is one of the most gratifying lectures that I give. And a lot of people think that it has to do with the T3, T4, and TSH, but it's really due to antibodies that are formed. So what is the most common cause of thyroid dysfunction? All of these right here, cancer, surgically induced, medical toxicity, and pregnancy and autoimmune, will cause a patient to be on Synthroid at some time. But the most common is autoimmune, which means antibodies or immunoglobulins are creating the autoimmune part. And this is really the whole crux of what happens in thyroid eye disease, are these antibodies that are thyroid stimulating, blocking, and peroxidase. These is where the immune system has gone awry and it's attacking the orbit. Unfortunately, the orbital structure. So if you think of thyroid eye disease, does it go to a retina doc? No. Does it go to a cornea doc? No. Does it go to a glaucoma doc? No. Where does it go if it needs something done? It goes to an orbital disease specialist. And we all know that there's hyperthyroidism and there's hypo and there's primary and secondary. So my point that I always like to do, if you're having a great day and you do confrontation fields, you pick up in a bitemporal hemianopia, you run the visual field, you diagnose someone with a pituitary adenoma, you send them off, they do the removal of the pituitary adenoma. You just broke down from the hypothalamus to pituitary to the thyroid. That patient ends up on Synthroid, but it's because of a secondary cause. It's these autoimmune conditions where the antibodies that are attacking the receptors of the thyroid actually go into the orbit and attack the fat and the muscles and create the problem. So there's two phases to thyroid eye disease. It's the T3, T4, which we don't really worry about. It's this congestive or this inflammatory or autoimmune part that creates the issue. Yes, you do get some side effects from when the patient first and those receptors are tickled, but they go away. That's not the inflammatory or orbital disease that we're concerned about. It's this congestive autoimmune part that we get concerned about with thyroid eye disease. And that's why these patients here all have thyroid eye disease, and their eyes did not end up like this because of T3, T4, TSH. Their eyes ended up because thyroid stimulating blocking or peroxidase antibodies are attacking the orbit. And you can see this patient's in a little bit more active phase because there's a little bit more redness going on. So this is kind of early in the orbital disease. This is late. This is soft tissue involvement. You can see the upper lid retraction, but it's these antibodies that are attacking the orbit, whether they're blocking or stimulating or whichever the antibody is using. Here is a real quick. See, this patient came in and she's like, "Doc, why am I on Lotemax? All these docs, these docs out there, ophthalmologists, optometrists, keep putting me on Lotemax." So I looked at her history. She's on Synthroid, looked at her, and I said, "I think you have thyroid eye disease." She's on Synthroid. You can see what her endocrinologist is doing here, but I ordered the antibody test. I didn't order T3, T4, TSH. I ordered the antibodies. And if you look here, she's less than 1, and it needs to be 20 international units or less per milliliter. The peroxidase is 11. That's acceptable, 35. Thyroid stimulating is 1.75. Here it's 1.3 because she wrote it down for me. That's what they're using. But look here, she's 344. She had 344 thyroid measuring on the thyroid stimulating immunoglobulin. That's what was attacking her orbit and creating the inflammatory disease. So remember, I'm going to go through this pretty quick because this is a whole lecture in itself. Thyroid eye disease can cause lid retraction. You could see the redness and the lid retraction in this patient. And there's the normal position of the eyelid. You can get von Graefe sign as the patient looks down from all the scarring and the inflammation. Chronic inflammation causes that eyelid to stay up. Here's the soft tissue involvement. This is not a bacterial or viral conjunctivitis. This is a patient that has thyroid eye disease, and she's in the inflammatory orbital stage. And here's a common condition out there called superior limbic keratoconjunctivitis. 65% correlation with thyroid disease. So when patients come in with SLK, I'll flip back in the chart and I'll say, "Oh, look, you're on Synthroid. You're having the autoimmune, the soft tissue involvement." Now, the other culprits are rheumatoid arthritis and Sjogren's. No surprise. What are they? Autoimmune. And what does that mean? Antibodies. Typically attacking the collagen and elastin. And what does the conjunctiva and sclera have? Collagen and elastin. So that's why the eye can be involved in a lot of these. And then we have the periorbital edema that can occur and the infiltrative orbitopathy that can occur with these. And there's just cases of them. A lot of people think that it has to be bilateral, as in this picture down here below, but it can be unilateral. And the number one cause, Dr. Salka has taught me, being the neuro guy, the number one cause of compressive optic neuropathy is not, like in this case up here, would you think an orbital tumor? It's actually thyroid eye disease that's out there. And what happens is these muscles continue to grow, and what's running through this muscle cone toward the apex of the orbit is the optic nerve. And it can be unilateral. And check out the muscle size of this patient here from chronic inflammation that's inside that orbit. And I got this from Elsevier in 2005, a patient that has a thyroid eye disease. You can see the hypertrophy of these muscles. And imagine that optic nerve trying to run through that muscle cone and the risk that that optic nerve could be. And wouldn't it be great if we have a molecule that can target? And last year, that molecule came out. So the treatments that are out there, depends whether what part of the disease you're on. In the active inflammatory, we're going to do palliative and then steroids and orbital radiotherapy. In the active, we can do bone decompression. Anyone that's on autoimmune, tell them to quit smoking. And then you could do lid weights and passive phase. And then you could do lid surgery. See that how white and quiet this eye is? The patient, the eye doctors before were saying nothing could be done. Well, I got her to a good oculoplastics and they fixed that left upper lid. And again, the soft tissue, you could go with artificial tears and ointments and steroids and maybe oral steroids for these patients. You might need an orbital disease consult on these patients. And the restrictive myopathy, you might have to get them to an adult strabismus surgeon once they go into the congestive or passive phase. And then optic neuropathy, you could use steroids and you could do radiotherapy or maybe orbital decompression. And you can get anywhere from 3 to 16 millimeters of retro displacement in this disease. Now, I wanted to set that all up because here is a patient that could have not come in any worse time, which means a year before Tepezza came out. And on January 25th, this gentleman enters into my office. And I think the first red herring that people might think is, oh, it's a gentleman, because thyroid eye disease or Hashimoto's or Graves is 7-to-1 ratio women to men. And this gentleman walks in and he has redness. He can hardly move his left eye. And he's been going to another practice in town. And they finally threw their hands up and said, look, we don't know what you have. You just got a really bad dry eye. He doesn't have dry eye. My technician actually came out and goes, I think you might want to use him for one of your lectures. I think he's got thyroid eye disease. I said, let's go in and find out. And she was 100% right. We got the thyroid antibodies. They were elevated. And you can see here, he's got soft tissue involvement. He's got periorbital edema. You could see this left eye is just not turning like it should. He's got the myopathy. He's got a very bad orbital disease. And what we did here is we placed him on oral and topical steroids. And I'm going to tell you who I use a lot of the time for these patients, not the endocrinologist, because they're going to be focused on T3, T4, TSH. But I use the rheumatologists because they're the ones that are really, really good at treating inflammation and going and working against those autoimmune diseases. So I started on some orals, I started him on some topicals, and you can see he got better. And over time, his swelling went down, his redness went down. And here you can see that he's on some orals. Now I'm working with the rheumatologist, and he's still on some topicals. And Tracy, you always like to point out here the side effect that's happening to this gentleman. Let me go back one picture and maybe a couple other pictures. And what is starting to show up here as a side effect of those oral steroids?
Well, it just shows you, it's only been a month since, Greg's first interaction with him, and between, what Greg was doing and then the rheumatologist in particular getting him on higher dose steroids, this is what you're looking at as getting into that chronic side effect of a steroid. The fat redistribution, you see he's going into that moon face, and he would have fat redistribution on the back of his neck, even in his belly at this point. It's remarkable in that short period of time because of the dose that they used.
Is that buffalo hump that they talk about?
Yeah, he probably has a slight buffalo hump in the back, but it doesn't take long. Doesn't take long.
So you can see here, from over time, his eyes got better. And then I finally didn't like what was happening over here to this eye, and we got him off to an orbital disease consultant. And it was just unfortunately too early. I'm going to actually just skip this poll. I don't think we need to do it because I've mentioned it a few times. Which biologic is indicated for thyroid eye disease? And it's going to be Tepezza, Tepezza or teprotumumab. It's not Actemra and it's not Avastin. And this was pretty neat. I was reading this. I do a thyroid eye disease lecture. It's one of my favorite and gratifying lectures. But in December of 2018, there was something, hey, teprotumumab, this insulin like growth factor 1 receptor antagonist potentially could be released. And read over it, and it appears that it can help with thyroid eye disease. And I was just totally excited because I treated a lot of thyroid eye disease, and it came out. And the reason why I said that is it was March of 2020, and it couldn't have been launched at any worse time, right? Whenever the world shut down from COVID, it did get approved. It's through Horizon Therapeutics. Its headquarters is in Dublin, Ireland, but it does have a US base here in Chicago. But look at this. When I talk about Chinese hamster ovary, this is what they use to make this insulin growth factor like 1 receptor monoclonal antibody. And you'll see right here, it is a monoclonal antibody, and it's using a Chinese hamster ovary. And then this is infused a total of 8 every 3 weeks to treat their eye disease. And really, here it is. This picture up here is, I love how they made this graphic. This is from their website, and you could see that it's an orbital disease. These thyroid stimulating antibodies are going in and creating this reaction. However, as you can see down here, it actually takes 2 molecules to turn on this inflammation. On this side, you see here's a receptor, and it's the thyroid stimulating receptor autoantibody that attaches. But that's not enough to cause it. You also need that insulin growth factor 1. And as soon as you get 2 of these touching this receptor, so it just causes that inflammation, causes the fat to hypertrophy, causes the muscles and inflammation, soft tissue involvement. You need 1 or 2. And you need both of those to be able to make that happen. 1 or 2 alone will not be enough. But what you can see here when we talk about targeted therapy is that what teprotumumab comes in, and it's got that insulin growth inhibitor, right? It's inhibiting this insulin-like growth factor inhibitor is now bumping this off, getting in its way. And even though the thyroid stimulating receptor antibody is here, it can't create the inflammatory reaction. And that's just how this medication works. It's very, very targeted. And they've done plenty of studies out there. And I wish this guy would have come in a year later so that we could have used Tepezza on him, because you could see here it works on proptosis, it works on diplopia, and the patient's quality of life score can improve. And there's plenty of studies out there with regarding teprotumumab and Tepezza. And the key here is it's very well tolerated. And it kind of makes sense now that one of the side effects is hyperglycemia. Tracy, you want to talk about that, since that's kind of maybe your realm?
Sure. There was one question that came across right after we moved from the gentleman with the proptosis into the drugs. Do you remember what dose of steroid he was on? Didn't he get some IV infusions as well with the rheumatologist?
He did. You're right. Yep.
Yeah. So, and I think the question's a good one. You know, what we always say with chronic steroid use, when you start to get those bigger side effects, they can occur within a couple of weeks. I mean, I've seen somebody who had lupus that started on oral steroids at about 40 milligrams, and in 12 days, she started to get the buffalo hump and the moon face. IVs tend to be worse. This gentleman, you get higher doses, so that's why it occurred so quickly. But in general, if this helps answer the question that came in, we say high dose or chronic use, long-term use. So anything greater than 20 milligrams per day really puts a patient in that category.
Yeah,
Everybody's a little different, but
I started off probably like some lodiprednol maybe, or pred acetate, topical, and then used a Medrol dose pack just to see if I can get a response. And when I did, then I called up the rheumatologist who were right down the street, and I think they said use 80 milligrams of methylprednisolone or something, 80 milligrams of prednisone, not methylprednisolone, 80 milligrams. And then it got the response a little bit better. Then I just said, hey, look, can you just manage this for me? And then they did. And that's where the IVs came out, Trace. So you're right.
yeah. And you can get the same effect with the oral, but it was a good question. So we've kind of moved up just a little bit, compared to Senargermin in terms of side effects with the teprotumumab. And, this lecture is designed to kind of go that way, but it would be even more shocking in a good way if we had started with, some of the Humera, the Enbrel, et cetera, or Actemra to see the potential side effects, because it really gives you a good perspective on how well tolerated both the Senargermin and the teprotumumab or Tepezza really are for patients. So this is ramped up a little bit simply because this is not a ocular med, and Greg will get into that as well. Most common adverse reactions: muscle spasm, nausea, alopecia, diarrhea, fatigue, hyperglycemia, hearing impairment, changes in taste, headache, and dry skin. Really, all of those, you look at them and you think, if this is really as life changing as it is, then most of those side effects are really a non-issue. The only one that we really are watching now in phase 4 post-marketing surveillance is that change in blood sugar. So essentially, it's because it's using a receptor, that insulin-like growth factor 1 receptor, and that can augment blood sugar in patients, particularly those that have poorly controlled diabetes. Even those that are euglycemic to start with, you have to be careful and watch.
And, Trace, you taught me, and not to make light of hyperglycemia. Hyperglycemia super high can kill a patient, but it's the hypo that can kill a patient. And that was when the insulins used to be out there, and we used to have crash carts and candy back in the Eye Institute back in the day, because hypo is bad. So I guess if you're going to get one, get hyper, but you don't want to go too high. So
yes.
So you want to talk about, there's the hyperglycemia. I want to talk about the infusion reaction?
Just very quickly again, we said the Senargermin was the ocular topical. This is now an injection. So anytime you're using an injection, one of the number one reactions is going to be an injection site reaction or an infusion type reaction. So real quick, it just says, 4% of patients in clinical studies, and getting into the post-marketing as well, transient increases in blood pressure, feeling hot, tachycardia, dyspnea, headache, muscular pain. Some of that can certainly even be just, anxiety associated with getting the infusion. That's very common. But these were pretty mild. You can start, because this is a naturally occurring substance. Again, I already mentioned the body's like, oh, no, don't like this. So some people, they already have an autoimmune disease that's occurring. So the immune system's already kind of jacked up and on high alert. So if it occurs more than once, or if it's severe, we pre-treat patients, antihistamine, acetaminophen, maybe even a steroid. And that's true across the board for all biologics that are systemic. And then we already mentioned the hyperglycemia.
So if you have a patient that comes in and they have just what I have found is, just go to the Horizon website, go to contact us. They're starting to open back up because of COVID. They're starting to build their team. I just had the medical science liaison reach out to me the other day, because I know I lecture on this, and we had a good chat. And So you can just type your question there and you're looking for an infusion center to have this done. I just did this talk in Utah the other day, and I had a doc come up to me and said it was amazing before and after. And they thought they might have pictures. So I'm hoping that doc sends them to me. So they said it's was remarkable, the inflammation before and after. So with that being said, let's jump into polling question number 7. And polling question number 7 is, which biologic is indicated for the treatment of non-infectious, intermediate, posterior, and pan-uveitis? Is it Oxavate? Is it Tepezza, Actemra, or Humera? Or you just don't know. Which one can be used for intermediate, posterior, or pan-uveitis? And looks like we got a pretty good mix here, but looks like it might be leading the race. I'm going to end the poll. I'm going to share the results. Trace, I'm going to let you talk about this because this is kind of more in your realm, but, and I'll assist, but, Actemra was 38%. We had a few people say Oxavate and Tepezza, Humera, and just don't know. And I'm going to stop the sharing and see if you have the controls.
Yep.
There you go.
So we'll get into, just a couple more pieces of information here as we head towards, more towards the end here. Greg, you can hear me?
Yep, can hear you. You're good.
Okay, great. So Humera, adalimumab, you can tell by the name that adalimumab is a monoclonal antibody. This agent has been around probably close to 20 years. It's one of our original tumor necrosis factor alpha inhibitors, which is simply a substance that tends to be high in people with rheumatologic or inflammatory conditions. So it was originally just indicated for rheumatoid arthritis, and then it sort of seeped into other inflammatory conditions. And it was pretty remarkable when, in 2016, it's been almost 5 years now, that the new indication was added for uveitis, the non-infectious intermediate, posterior, and pan-uveitis. Greg, you want to mention anything about that?
No, just that, a lot of people think that you can use this maybe for iritis, which is because it says uveitis here. Anterior uveitis is really not on the table. Maybe if someone just can't get it cleared up, but this is more for the posterior, obviously non-infectious because you're going to shut down the immune system here, but intermediate, posterior, and pan-uveitis.
Okay, good enough. And it just shows you that it is, once again, an injection. This can be given as an infusion, or it can be given by the patient themselves as subcutaneous injections. Most of these products that can be given at home as subcutaneous injections, like insulin that's out there now, have pens or auto injectors. So patients don't have to know anything about injecting themselves, and it's what we call an auto injector. It's pretty remarkable for people. I wanted to mention at the bottom here, it says the significance of this FDA approval, this Humera adalimumab, the additional labeled indication for this uveitis is.
What if I told you there's a way to
double.
fix your slice in 15 golf swings?
Hold on.
Would you believe me? Well, here's a
It has two important
golfer
components.
who's coming way over the top, as
Hold
you can
on,
see
Trace.
here. And within
Let go of the remote, please. Let me have control.
Whoops, hold on.
Go ahead and try. I got something spinning in the background. I might come back up again. All right. Now you got it. Go ahead.
Someone's working on their slice. So with the adalimumab and the approval, I was just mentioning that, not only is this important because then Medicare will typically pay for it. Medicare many times must have a labeled indication. They're not really impressed with off-label uses. And even more so, additional insurances, commercial insurances, for medications that are several $1,000s a dose, are usually like, nah, let's just put the patients on a steroid or some of these other low-tech treatments, which is all we've had in the past. So the fact that we are getting so many of these biologics in the ocular arena is going to be life-changing for your scopes of practice as well as for patients, really truly. So let's see what else we have here. Moving along to monitoring parameters, we'll keep it moving. This is where we kind of looked at the Sendergerman, really innocuous. The teprotumumab, fairly innocuous, some infusion reactions. Now here we've got the Atolimumab Humera. This is where we saw the original players in that biologic arena, that they have to get a PPD placed. Usually they'll test them for tuberculosis and maybe hepatitis as well. Again, the reason being, once you start a drug that's suppressing the immune system, and Atolimumab Humera for this uveitis is a immunosuppressive agent. So if you suppress a patient's immune system, two things can happen. One, you, in terms of infection, you will all of a sudden suppress the immune system enough that an opportunistic infection all of a sudden rears its ugly head. And that includes if you have tuberculosis living in your body and it's latent, or hepatitis, etc. Then the second thing that I want to mention is, don't forget about if patients have any signs or symptoms of acute illness, then again, the Humera or Adalimumab or any of the others I'm going to mention briefly cannot be taken until they improve. So the other thing is, we're tinkering with the immune system again, starting here with Humera, Adalimumab. You're going to see those potential cancer warnings as well, particularly lymphoma. So let's see what else we've got here. I just wanted to mention with these last couple of slides, first, the biosimilar. Look at this guy. It's got a brand name to it that the Biosimilar Company added. So it's Hadlima, but it is Adalimumab BWWD. So forget the branded biologic, or biosimilar, pardon me. It still would be able to, like Greg was mentioning in that registry, as all of this data is continually updated, you'd still be able to see like, oh, okay, maybe the Adalimumab BWWD, the biosimilar, the outcomes are slightly different than the biologic. I'm not saying there are, I'm saying that's how we would be able to track that information. So then I'm just showing you what we call a black box warning. So in my world, and this translates into your world as well, when the FDA deems something very, very serious in the decision-making process of whether or not you want to use this in your patient and whether or not the patient wants to use it as well, we have a black box warning saying, here's Humera, Adalimumab, here's Hadlima, Adalimumab, BWWD, but wait, you better make sure you really want to use this in your patient. So it says, warning, serious infections and malignancy. It talks about the infections we mentioned in a little more detail, and there's that malignancy at the bottom. This is with all of the biologics that are not the Sendergerman or the VEGF agents you've been using, the Sendergerman, nor with the teprotumumab. All the others have this warning of similar ilk as you go from one to the other.
And that had a black box around, and that's literally what pops up on your screen, right? So.
Yep, they call it a boxed warning. That's what the FDA calls it, but it's sort of colloquially taken on the name black box warning. Sounds worse, I guess.
So the answer to the last question was Humera, and now we're going to launch this one, and maybe by process of elimination, which one is used for giant cell arteritis. So all of these, Humera, we see it on TV all the time. I just wanted to point out that it does have a ocular, which is the posterior uveitis, and now we have one here for giant cell, and I'll let you jump in here, Trace. I'm going to end the poll. We got a pretty good amount weighing in. And the majority are figuring it out that it's the Actemra. I'll share the results. And I'll stop sharing and get it off my screen and see if you can take over, Trace.
Yep. Okay. So now we have the Actemra, the Tosilizumab. You can see that this also is a monoclonal antibody. Once again, like the Atolimumab, the Humera, Actemra originally started it came out a little later than the Humera, the Remicade, the Enbrel. It came out maybe 15-ish plus or minus years ago. It was a slightly different mechanism. So basically they figured out, well, okay, a lot of people have high tumor necrosis factor alpha. A lot of people have, high tumor necrosis factor alpha inhibitors, but it doesn't work in everybody. So patients must have other levels of cells that are high for a different reason other than the tumor necrosis factor alpha. So in comes Tosilizumab Actemra, a wonderful drug. It's now indicated and has been for several years for the treatment of giant cell arteritis. So what you see in a lot of these patients is not only, a good chunk of the giant cell patients, some, will start with polymyalgia rheumatica and then have kind of the co-diagnosis with giant cell arteritis. So the beautiful thing about the Actemra in particular, and this is a graphic I love because it shows you based upon the different colors, bubbles, the names and what their mechanisms are. Actemra is an interleukin-6 inhibitor. But what you get is with this co-diagnosis, a benefit in patients where you get an improvement in their polymyalgia rheumatica as well as in their giant cell arteritis, which interestingly, I have in both my mother-in-law as well as my own dad started on Actemra now, and it is both of them improved dramatically with their signs and symptoms on this medication. Truly, truly life-changing for both of them. It was the first innovative therapy for giant cell in over 50 years. The standard is always really the steroids, the oral steroids that we see in patients for giant cell. Biggest problem with some of the steroid protocols is that we tend to taper them too quickly. And as soon as the patients then get tapered down to doses less than 10 or 20 milligrams, then many times they have, the rebound in the giant cell symptoms again. So the beautiful thing about Actemra is it was compared in clinical studies, Tosilizumab, the Actemra, to placebo and prednisone doses. So I'm not going to go through all the data, but the long and short of it is the endpoints were, do patients do better on Tosilizumab in terms of they take less steroid? And if they do take less steroid, can they take it for a shorter period of time? And for comparing it to placebo, the placebo had just two different lengths of time for the steroids. So one was a 26-week prednisone taper, the other was a 52-week prednisone taper. So both arms had, well, all three arms really had steroid involved. It's just that the one had Tosilizumab plus a steroid and the placebo had just the steroids. And I do see some questions popping up there. I'll get those in a second. I'll be glad to. In the end, it was discovered that yes, the Tosilizumab not only decreased the amount of steroid that the patient used over the 26 and 52-week arms, but that they could take it for a shorter period of time, which is really, why take the Actemra if you can get great outcomes on prednisone for a short period of time? Well, we know that that's not the case in most patients. So it's that cumulative long dose that we end up seeing, and that's really detrimental. So the question, I think, was twofold that popped up. What were the signs and symptoms of both your dad and mother-in-law, typical GCA, and did they do biopsy prior to prescribing? So they had kind of, similar. My mother-in-law presented first. My dad is 77. My mother-in-law is 81. My mother-in-law presented first. She actually had polymyalgia rheumatica that was a result of almost dying on a statin that she should have never been on. And she went into a horrible kidney issue, muscle breakdown, which is what started the polymyalgia rheumatica. About 3 months into the severe polymyalgia rheumatica, she started to have the very typical signs and symptoms of giant cell. They did biopsy her eventually, and it did end up showing giant cell arteritis. My dad, his polymyalgia rheumatica was very severe, and in essence, wanted to stay on the steroid because he kept thinking, oh, it's going to get better, it's going to get better, that type of thing, and it just didn't. So after horrific side effects for both of the diagnoses on steroids, after 2.5 years, I finally got him to do the methotrexate, and then we did hydroxychloroquine, a little better on those, still high doses of steroids, and now he's finally I will, after 2.5 years of being on 20 milligrams of steroid, he has complete muscle myopathy. It hit the speed train for his cataracts, and really awful steroid side effects. So this drug is life-changing and amazing. Same type of thing. You can see the warning, risk of serious infections, etc. And Greg, I think we're kind of heading to the end here.
Yeah. So the one I want to point out there with the Actemra is that we saw in that gentleman that short period of time that I was treating with the thyroid eye disease, how just that, if you want to say large or small amount of steroids in a short period of time, created those side effects. So the beautiful part of the Actemra is that you're decreasing the amount. And then Trace, I'm going to get to the end here because we did reach our limit, but you did point a few out here. There are biologics, no ocular indication, but you might see these in practice. What are these two used for here? And then I'll click through.
These, just real quick, these are what we call Janus kinase inhibitors. They're the oral, the injections that we call from Xeljanz, the original. So this is the new thing for rheumatologic conditions, is trying to use oral biologics. And these two, baricitinib and upadacitinib, I just say Rinvoq, it's the one I can't pronounce. They're used for rheumatologic conditions, typically not first line.
And then you have these in family medicine here that are mainly used for what here? What do you have these for?
So these, everybody has seen these on TV, in commercials, in magazines, etc. These are those new preventive treatments for migraine. And again, life-changing medications. We have never had anything so good. We've never had anything actually with a labeled indication for migraine prevention. These are just a couple of them that are now in this class of calcitonin gene-related receptor antagonists. But I know I don't have enough fingers and toes to count the number of people that are on these biologics to prevent migraine headache that say, oh my gosh, where have you been all my life, to these medications. So just to kind of mix it up and show you the variety of meds in the biologic category that you'll see, many, many more as every year passes.
So there are a few coming down the pipeline. We're not going to talk about those. We'll cover that maybe in a different lecture. And with that being said, Joe, are there any other questions? I'm going to, before thanking everyone, just check to make sure that there's no other questions that are out there.
I don't see any additional questions, Greg.
No, there appears to be none.
All right. And William, thanks. I see this one here. Thank you for the very kind comment. I'm going to say thank you, everyone, for attending Ocular Biologics, Biosimilars, and Drugs. Joe, thanks for hosting us tonight and being moderator. And it's truly an honor and a pleasure. Tracy, I'll let you say a final comment before I move into some housekeeping.
Thanks, everyone. It's been truly a pleasure. I always say I finally found my niche in life to be an optometricentric pharmacist. I even made up that word, but it works.
Yeah, I like it.
Thank you.
Thanks, everyone.